So our next speaker is Dr. Subhendu Boral. He's from Disha Hospital. He's a prolific retinal surgeon and mostly expertise in subretinal surgeries. Now he'll be talking about macular hole and retinal detachment, how to deal and what are the tips and tricks.
Although both of these conditions have well-defined surgical treatment approaches. The coexistence of these two conditions is a challenge to the ear surgeon that must be addressed with a particular philosophy. And the surgery of for this concomitant macular hole and retinal detachment requires different approach from the traditional techniques. Standard approach of handling this kind of disorder uh, in the same patient are standard PPP along with PMD induction, peeling ILM without use of heavy fluid PFCL. So PFCL is somebody can use. I will discuss one by one. Fluid adduction followed by either long-acting gas in ISO expansion concentration or silicone oil as a tamponade. Pre-operatively, it is very difficult to diagnose the macula because the macula is it depends on the elevation of the macula. Sometimes you'll do OCT, but you cannot see the neurosync retina. It is elevated so much. There is so much like height of the macular is height. It is so it is not captured. It cannot be couldn't captured by the OCT. So these are the few cases where I took the photograph of this macular OCT where the OCT is showing the macular hole, and sometimes even in all macular off cases retinal detachment, we are not convinced traditionally doing the OCT in each and every macula of retinal detachment cases. So vitrectomy with ILM peeling is an efficient and safe procedure for the macular hole induced retinal detachment, and removal of the ILM contributes to the successful reattachment and is effective treatment for the macular hole and detachment in high myopia eyes. They are already published in Retina 2004. There is no evidence of benefit of ILM peeling in terms of primary outcome, that is the measured BCV at 6 months, and ILM peeling appears to be superior and cost effective in low peeling counterpart, as it offer more likelihood of primary anatomical closure. That has already been described by Spiteri, Cornish et al. So you should always remember that it is mandatory to attempt to avoid letting dye pass through the macular holes to come in the direct contact with the RP. That means previously we are using ICG. Nowadays almost very few of us practically were not using ICG because it is more toxic, and whereas the more safe dye is available, that is BBG. Better to aspirate the ICG if you are using ICG till date at all. So you should aspirate out the ICG with a soft tip cannula, including that may accumulate under the retinal space and cause damage to the subretinal and cause subretinal toxicity. So why it is very careful not to avoid the direct contact with the RPE cells. Without PFCL, do not expect to achieve continuous macrodexis, patchy removal of the ILM. Rather, it is advised by the it is achieved by the sectors. Another thing is try to avoid the if you are not using PFCL, you have to hold the ILM flap away from the macular hole margin as well as from the peripapillary bundles. If you hold it at the macular hole margin, that can anyway extend the whole margin also. To avoid excessive elevation of the macular retina during this procedure, and also it is important to minimize the light exposure to cause phototoxicity of the foveal tissue, and avoid the remaining fluid to be withdrawn, avoid the accumulation of fluid at the margin of the macular hole. That will cause recurrence of retinal detachment. Small amount, it should be absolutely dry. So what are the pros and cons of using heavy fluids PFCL? PFCL, it can stabilize the posterior pole, it can exert counter traction. That is the biggest advantage of PFCL, but there is always potential risk of PFCL getting going under the retina through the macular hole. If the whole margin is having some kind of traction because of intrinsic retinal traction or unpeeled membrane, so especially in detachment, the high macular retinal rigidity is very high, and the margin of there is posterior staphylinoma in high myop. in this case of ILM peeling in detached retina, where you can see during vitrectomy also the hole has a little bit enlarged because of aspiration, because of the suction induced, cutter induced aspiration through the macular hole. And I've stained the ILM with the help of BBG, and without using PFCL, I am peeling the membrane. Just see that the retina is I am elevating the retina at the macular area, and there is no continuous macular axis. Patchy removal of this ILM is possible, and slowly you have to keep your patients without using PFCL. It is very difficult. It is to peel this kind of ILM from the detached retina. So finally, I have just succeeded to remove all the ILMs, then injecting PFCL to stabilize the posterior pole and doing the fluid exchange from the peripheral break. This is another case where I am fixing the posterior pole with the PFCL, and after staining the ILM, and then using the Tano scratcher to lift up the flap, and trying to peel the ILM in a continuous manner, and it is very in a controlled way. You can see, and slowly I am removing all the ILM around the macular hole. It is not mandatory to make the whole ILM peeling area to increase that much. That is more than 3 diameter, more than 2 diameter. It is not mandatory. Just peel the ILM in a decent size. 2 diameter is good enough to get the closure. Another thing is inverted ILM flap technique that we are routinely following this thing. Macular hole per se can cause retinal detachment, but there is always probability of peripheral breaks, like in this case. So here I stabilize the posterior pole without injecting the dye. Now using the soft tube cannula, I've gone inside, and under the PFCL, you just start from the temporal disc margin, inject the dye. And this kind of approach will stain ILM better, because the dye will be there between the PFCL and the retina. It will try to retain the dye under the PFCL, and then you can do the ILM peeling under the PFCL, sub PFCL ILM peeling, and just peel in an inverted peel manner. So inverted flap technique that will increase the chance of closure in case of macular hole with retinal detachment. It is very high, almost like 100% cases. Very badly you can get, even as a the young generations, those who have already not done, it is maybe their first case. If you are trying to peel the ILM in a detachment case, like with the help of PFCL, you can get this. If you can close the macular hole with the ILM, you will get 100% closure rate in your case. So you can increase the ILM peeled area, and then followed by fluid exchange through the peripheral break, and do the vitreous base excision, followed by internal fluid drainage through the peripheral break, and settle the detachment, and do all around 360 virus laser. Finally, cyanic oil or gas at the end of surgery. When it was at infranasal break, I put injected oil. So after 4 weeks, there was nice closure of the macular hole without you cannot see the ILM flaps. It's nicely closed. Another thing is surgery like inverted ILM flap technique in detached retina under PFCL, where I'm staining the ILM under the PFCL with the help of silicon tube backglass needle, starting from the disc margin going towards the macular area, and then slowly peeling the ILM. And gradually you can increase the size of ILM peeled area, and finally keeping the ILM tags around the macular hole margin, and just cover the macular hole with this ILM flap. Then you can increase the size of the macular ILM peeled area, and then followed by fluid exchange after doing vitreous base excision. And so after 4 hours of this surgery, you can see the hole is not closed, but still it is closing. You can see the ILM stub inside the macular hole area, and after 3 weeks it is nicely closed. And if you follow up this type of cases, This is another very interesting case, post-diabetic vitrectomy, recurrent retinal detachment, open large macular hole where there is recurrence of retinal detachment in a combined retinal diabetic combined RD. There are a lot of tractional proliferation happened, so that and secondary macular break, and as well as a lot of PVR changes. Patient came late, so a lot of PVR changes has happened, and whole margin is quite rigid. So how to deal this kind of case? Like I'm trying to remove the membrane, but retina is so friable and thin. I could have created a lot more breaks. So slowly I'm trying to remove all the rigid visible membranes after staining the dye, and finally finally there was a lot of peripheral traction also. So I had to do the 360 peripheral retinectomy to make the retina free from all the peripheral attachments, and finally injected PFCL to stabilize this central retina, and they used the curved scissor to take the peripheral retina, and with the help of this phenaciplex loop, I covered this ILM over the macular hole and cut the residual retinal tissue towards the periphery, and completed a 360 barrage laser, and finally used silicone oil. And after post-operative 3 weeks, you can see the island of retina, central retina is there, and you can see the hole is closed. So inverted ILM flap technique improvement in BCV is significantly better than the inverted better in inverted flap technique, and primary closure rate also 100% in comparison to the non-inverted flap technique, like in 55.5% closure is happening, and no significant difference in the retinal detachment. Redetachment rate is there in both. Thank you.
So nice presentation, Dr. Boral. And suppose if you don't have PFCL in OT, then what is the choice of ILM peeling? How you can proceed with ILM peeling in detached retina?
You have to make it sure the PFCL should be available before starting the OT.
So
like anytime you can do the ILM peeling like without using PFCL.
It's a difficult procedure, but it can be done.
It can be done. It can be predictably done. Otherwise, you can create much more elevation, retinal elevation from the macular area. You can create the break formation from the.
So you have to be very careful while picking up the ILM in the detached retina. You can tear the retina, make the macular hole more larger.
Actually, not in your IC, but I'm telling you, when there is ERM as well as boggy macula, like in diabetic ERM, too much of fluid is there in the and overlying there's ERM. So you have to remove the ERM for injecting the. You have to remove the ILM also. In those cases also, if you are using PFCL in any boggy retina, in any boggy where there is big serous detachment in the macula, you can just confidently do the ERM removal ILM peeling. So it is not, there is no hesitation. There should not be any kind of hesitation using PFCL. It should be used liberally. It is a real friend, like Rupak Kanti Biswas. Rupak, please.
What he told is absolutely correct, but with the Dr. Nandi's answer, if at all, if the PFCL is not available or sometimes, then the other option is that you can, in fluid presence, you can initiate the ILM flap and then do FG. Under FG, if your visualization is very proper, then probably you can, put the flap again into the hole. So that is now another way of doing it. But again, PFCL is the choice.